Our final presenter today is Emma Chambers, and she's going to cover the really tricky paediatric and neonatal blood transfusion topic. Now, I appreciate that unless this is your bread and butter in labs and you have paediatric wards and neonatal wards, actually in typical hospital labs, coming across any children is utterly terrifying. So I think that actually this talk is excellent and really helpful. So just to give a little bit of background to Emma, Emma also works at Southmead in North Bristol Trust with Tim, where she previously was a senior biomedical scientist, but she's since begun her pathway to becoming a consultant clinical scientist via the HSST. She's got 20 years experience in heme and BT as a BMS, and she is passionate about transfusion safety and the appropriate use of blood.
Okay, so I'm mostly going to focus on the neonatal elements because obviously that's the most complicated. We do have a neonatal unit at Southmead, so we do this quite a lot. I appreciate it does cause quite a lot of confusion for people who aren't used to it. It's mostly red cell related because that is the more complicated part of neonatal transfusion. And I thought I'd just start with some definitions because this does confuse people. A neonate, strictly speaking, is up to 28 days old, but obviously when you're dealing with premature infants, that doesn't always tally. So we would generally say up to 28 days past expected date of delivery. An infant is 28 days to 1 year, and then obviously a child is 1 year to adulthood, which varies depending on what kind of setting they're in. There are some specific age-related challenges. For example, they can't identify themselves, which obviously if you're approaching a patient to take a sample or to start their transfusion, you ask them to identify themselves. You can't do that with the baby, obviously. So they'll be wearing their wristbands. They generally either have 2 wristbands or have what they call a cot card, which is the identifier in the cot that stays with that baby at all times, because some of these babies are so small, their skin is so thin, they can't wear a standard wristband. So that in itself is a tricky issue with NICU. Okay, names often change. So these samples are valid for up to 4 months. They come in as baby Smith, and then they're given a forename, or maybe they've been given the maternal name when they arrive, but they're actually going to be known by the paternal family name. So it all changes. And we've had babies that have been on NICU for 6 months and have completely changed their name in that time. So obviously when you're looking at a sample that's valid for 4 months, there's a bit of a challenge around what name do you put on the actual unit that you issue. They can't tell us if they're not feeling very well. Obviously, babies make a lot of noise, but it's very non-specific. So is this baby crying because it's feeling hot because it's having a transfusion reaction, or is it just crying because it's a baby? Yeah. So they can't tell us what's happening, the same as with an adult patient. And it's really difficult to get good quality samples from a baby. And there's a risk of misinterpretation of the results because these samples are tricky. So it could be, if it's clotted, you can misread the platelet count. If it needs to go for a blood film to confirm the platelet count, is that still genuine? Are there fibrin strands in there? Could it have been clotted? It's very difficult, and people are reluctant to ask for a repeat sample on a NICU patient. But obviously, if you don't, you've got the risk of over or under transfusing because those results haven't been interpreted correctly. So we try to use the smallest possible sample for NICU babies. Now, in our transfusion lab, we actually have false bottom tubes because they work better with the analyzers. So you've still got this tiny little 1/2 ml tube, but it's inside a bigger tube. So the analyzer, it's easier for labeling and for the analyzers to find the sample. But this tiny little tube is the equivalent of 16 sample tubes from an average adult. So those poor babies that are being rebled for their full blood count, for their clotting, their chemistry, and transfusion if required, they're losing a lot of blood just in sample volume. I was quite shocked by that when I read that. If I represent this visually, that's quite a message, isn't it? How many? Oh, there's still more. How many sample tubes that uses? And their morphology can be very, very difficult to read as well. So if you are in a situation where you've got an anemic baby, maybe they were known to have some maternal antibodies and you're expecting it, maybe it's completely unexpected and you have to look at that blood film. Reading a baby blood film is an interesting experience in itself. You can see this is an example of a relatively well baby, and they've got some nucleated red cells, they've got there's some target cells, there's all sorts of fun stuff in there, there's some spherocytes. It's really difficult to read a baby film and what's clinically significant and what isn't. Okay, so taking a step back chronologically, I'm going to talk about intrauterine transfusions. So these are obviously the ones we could do before baby's born. We're lucky we live in an age now where this is relatively rare. But when you speak to older BMSs, they'll talk about this kind of thing happening every week. Before the incredible invention of prophylactic anti-D, it was really, really common for women who are D negative with D positive babies to have invasive treatments because they developed anti-D. It's a very invasive procedure. Imagine it's a great big needle going through the woman's abdomen into the baby. So it's ultrasound guided, but obviously it is still very risky. There's a 1 to 3% chance of fetal death and up to 20% risk if the baby is already hydropic, which is obviously a massive risk. These are performed in specialist centres. To be classified as specialist centre, they have to perform a minimum of 15 per year. So that's a lot these days when you think it used to be very standard. That is a lot of patients being referred. So it's quite a centralised service. In Bristol, any babies affected in this way would be sent to our neighbouring hospital for treatment. We don't do these at Southmead. And there's a lot of complications that can be associated with this procedure. Miscarriage, preterm labour, fetal bradycardia, cord hematoma, vessel spasm, and all sorts of other unpleasant and scary things that can happen to both mum and baby. So obviously this isn't something that's undertaken lightly. Okay, and once the decision's been made that IUT is the way forward for this pregnancy, we then have to be very careful about what units we're going to give this patient. So it has to be ABO and D compatible. We most commonly use O-neg for this. And obviously, a lot of the time you won't know the baby's blood group unless we've also had to do fetal blood sampling for some reason. And it has to be negative for any relevant antigens for the maternal antibodies, whatever that may be. As I say, it used to be most commonly anti-D. We don't get that so much now, thankfully, but little c, cal, and sometimes we can do this for babies who have been infected by parvovirus. So if mum's had parvovirus during pregnancy, it can cause aplastic anemia in babies. So the baby's just not producing enough red cells, so we'll do an intrauterine transfusion to boost that baby. It's cross-matched against a maternal sample. It has to be cal-neg unless the mother has got an anti-little k antibody. It's a high hematocrit because you're trying to get as many healthy red cells as possible into that baby and in as small a volume as possible. It has to be irradiated, and it has to be irradiated before the end of day 5 after donation and used within 24 hours of irradiation. So it's got a very short expiry on it because of the risk of potassium leakage caused by the irradiation. It's CMV neg, high titer neg. And this one was interesting and probably quite tricky. I've never physically been involved in an IUT, but you can't transfuse it straight from risk of the temperature shock to the baby, which does make sense, doesn't it? I imagine quite a lot of adults are uncomfortable with feeling a cold unit going into them. But there are no designated small volume blood warmers. So I need to find out a bit more about how that's managed logistically. That sounds like an absolute nightmare to get that to a reasonable temperature safely. Obviously, you don't want to warm it up too quickly, cause hemolysis, because that's just going to exacerbate the problem. So if anyone on the call knows how that's done, that would be really interesting to know. I need to find out a bit more about that. Okay, so we've then reached the point in our pregnancy where a baby has been delivered, but they're unwell. So this might be a baby who's had an IUT. It might be this might be the only intervention that this family have needed. So we might need to do a neonatal exchange transfusion. So this is mainly used to treat hemolytic disease of the fetus and newborn, to prevent bilirubin encephalopathy. It used to be known as kernicterus, and this is where we get plaques forming on the surface of the brain, which affect neurodevelopment. And it can be used to treat high or rapidly rising bilirubin that's not responding to other treatments. Again, this is something that's improved massively in the time I've been, at the hospital. Obviously, phototherapy has been used for a very, very long time, but the use of IVIG, I remember that being new, and there being some confusion over dosing, and having to call my transfusion consultant. Somebody's done this wrong. The decimal point's in the wrong place. They're asking me to give more than this baby's entire blood volume, and having to recalculate the dose for this baby. So yeah, that's something that's quite new and quite successful, and has reduced the number of neonatal exchanges we've had to do. And again, this is very rare now. You can talk about it with, again, older colleagues will talk about doing 2 a week. That I think I don't know what Tim's opinion on this is, but I think we probably get 1 a year, if that, now. And it works by removing antibody-coated cells and excess bilirubin. A single volume exchange will reduce the coated red cells by, I think it's 70%, and a double volume will reduce it by 85 to 90%. Which way that's going to go will be based on gestational age, fetal weight, degree of jaundice and hyperbilirubinemia. There's lots and lots of factors. There we go, I had written that on there. Okay, so to select our unit for our exchange, again, it's very important to get this right. It needs to be ABO and D compatible with mother and baby. It's usually group O, and negative for any antigens that there are maternal antibodies for, obviously. They're always K-neg, CMV neg, high titer neg, and we've got a slightly lower hematocrit this time, but still higher than in physiology. And again, this is a delicate balance to reduce the risk of post-exchange anemia and polycythemia. Obviously, you don't want to go one way or the other. It's a very tricky balance. And again, we've got this short expiry date based on irradiation, and for the same reasons, to reduce the risk of potassium leakage. There are blood warmers for these exchanges because it's a larger volume. And something that often catches people out is, if you are ordering a unit for exchange, make sure you've checked what volume of exchange they're planning on doing. Do you want 1 unit or do you want 2? Because the last thing you want to do is have to call hospital services and tell them you've made a mistake and they actually need a second unit. Been there, done that. Okay, small volume transfusions for neonates are much more common. Generally used to treat anemia of prematurity, which is often due to iatrogenic loss. So this is what we were talking about with sample volume. If you've got a baby that's on NICU for a long time and you're bleeding them every couple of days, that's going to use up quite a lot. It's generally transfused at at 15 mil per kilogram. And again, we're talking tiny babies. This is going to be really small volumes. So these come in a neonatal split pack, which has a 35-day expiry. And same as an adult size unit. Because you're giving smaller volumes, you don't need to worry so much about the potassium leakage. The transfusion thresholds are quite complicated. I was going to put in a table of this, but I forgot. It depends on gestational age, condition. Are they ventilated? Are they not ventilated? You know, it's quite complicated. It's very difficult when the neonatal unit phone and ask for a transfusion. It's very difficult to keep track of who's on what kind of treatment. And we have to consider donor exposure for these as well, because obviously these are babies that might be in for a very long time and might need a lot of units. So you don't want to expose them to more donors than is absolutely essential. So these come in split packs of 5, and it's good practice to assign a pack to specific babies. We've worked this out locally based on our own population. We would have 2 babies assigned to 1 split pack. Unless, of course, there are any special requirements, in which case you would obviously manage that individually. We try not to put twins on the same split pack because they use a lot, so you end up with more donor exposure. Yeah, it's tricky because obviously you don't want to waste units, but also you don't want to split those across more babies than you have to. Okay, again, these units are usually O negative unless by special arrangement due to maternal antibody. We did have a situation at Southmead a few years ago where we had a lady who we knew had an anti-little c, and she'd come in labour, so nothing was ready because she wasn't due for another 6 weeks or something like that. And so we didn't have these units in for this patient. And I remember talking to the NICU doctor saying, whatever you do, don't give that emergency stock. It's going to make this worse. I guarantee that unit has got the C antigen. We will get you the right, and we did get a D positive split pack in before baby was born. But that doctor phoned me back afterwards and asked, I don't understand, how was the emergency stock not going to help in this case? So that was a really good education opportunity that obviously your average doctor doesn't know about the different RH antigens and things. That's not their job. That's what we're here for. So that was a really nice opportunity to sort of educate a bit on that. But the baby was fine. We got the units in time. She didn't need exchange, but she did need a few top-ups, and we did have our special units from the super duper blood service at Filton. They are K negative, CMV negative, high titer negative, and as I said, they've got the 35-day shelf life. If the baby has had an intrauterine transfusion, then these units will need to be irradiated, and that will reduce the shelf life, because obviously all irradiated units have a shorter shelf life. Okay, this is the bit where a lot of BMSs get confused. Who are we testing for what when you've got mum and baby? How are we testing these samples? So for the maternal sample, we need to know the ABO and D antibody screen, and if there are any antibodies, we need to know what they are. The sample can be collected up to 3 days pre-delivery or up to 7 days post-delivery. If they have delivered at another hospital, which is again is very common because NICU beds are spread around, you can contact the hospital where they delivered and get any information possible from there. Obviously, with some of the networked systems that are coming along now, obviously we've got Spice and some of the maternity IT solutions, you can log in and see if there's any significant history. It's not foolproof, so it is always best to phone, but you've kind of got that as a backup. Okay, and on the baby sample, we want the forward group and the D type, because obviously babies don't have a reverse group, and if they do, it's probably mums. We would do a direct antiglobulin test if there's evidence of hemolysis or any maternal antibodies. And if the maternal sample is not available, then we're going to test baby for antibodies. And again, this can all be obtained from the place of birth if the patient has been transferred. Obviously, because all neonatal units are O negative, if the baby has been transferred at the hospital of transfused at the hospital of birth, we're not going to get a clean blood group. And depending on how many units they've had and how small, what proportion of their blood volume that is, we may or may not be able to tell at the receiving hospital what their blood group is. So again, that would be a phone call to the place of birth to find out what's been given. Babies don't need to be cross-matched until they're 4 months of age. So these samples are valid for up to 4 months. This is because babies don't develop antibodies in the first 4 months, even if they've had multiple transfusions. The immune system just isn't developed enough. If you think about how anti-A and anti-B in the reverse group develop, it does take time for that to happen. So obviously, any additional antibodies just don't develop at that age. Okay, so I was going to put in some more about the microbiology testing and things, but I just ran out of time. So donor testing and selection for neonatal units. There are slightly different criteria. So donors would be selected if they've given at least one donation in the last 2 years. So we want these to be people who are relatively regular donors. The current donation has to be negative for all the mandatory markers. Obviously, that's the same for any donation. And there's also the PANTS test for additional antibody screening for paediatric units. They are CMV neg, hemoglobin S, and I hope that was helpful to some of you.
Neonatal transfusion is terrifying, and the terminology is so confusing as well, because see what a hospital class is as a neonate, and actually, really we should be giving neonatal blood to anyone under the age of 1 as well. It can get really confusing with the clinical area, can't it?
Yeah, it can. And I find with our babies, because we have got quite a big NICU and we take some very, very, very prem babies, a baby who's 3 months old can have very different requirements to another baby who's 3 months old, just because of what the gestational age was at birth. So it can be really complicated, and people get very confused over maternal sampling and fetal and neonatal sampling. And obviously, we can get a cord blood sample, that's really helpful. So that's a non-invasive first blood group. But obviously, you don't always know. They're not always ready for that. Sometimes these babies come very quickly and unexpectedly, so they're not always ready with their cord blood collection. And so it can get very complicated, and it varies a lot from patient to patient.
Absolutely, and I've definitely found that lab staff tend to freeze the minute anything happens. The really boringly, just aside, but if you're in a hospital that doesn't necessarily deal with intrauterine transfusions, and kind of all of your pregnancies that's slightly tricky go off to a different hospital for care, it's always really helpful to know if they've had an IUT, because that increases the risk of alloimmunization as well. So mum may go off with 5 antibodies and may come back with 7 antibodies because she's had that further exposure. So it's such a minefield. Such a minefield.
And these ones have got multiple antibodies as well. I mean, I love doing antibody panels and things. I'm a bit of a geek. But when you're faced with a pregnancy that's got multiple antibodies, it's no longer fun, is it? It's a logistic challenge trying to find suitable units. And obviously, there's always plans in place for the expected date of delivery and at what point we'll bring them in for induction and so on. But unfortunately, babies do what they want, don't they? And sometimes they sneak up on us.
Isn't that all patients, no matter what guidelines you have? That it's beautiful. but you know, turns out the patient hasn't read the guidelines, and they will do. Come in.
Yeah. I always say when we're doing the junior doctors training, I always include, you know, we've got all these guidelines, but there will always be a patient that doesn't fit the guideline, because we're people, we're human beings.